Good morning, dear colleagues. It is my honor to present you my PhD thesis called Functionality and Aesthetics in Plastic Surgery. My name is Péter. I'm a fifth-year medical student and also a PhD student. My vision is maximized patient health and satisfaction in plastic surgery, and I want to achieve this by identifying and implementing the safest, most effective procedures. For this, we have outlined two specific goals, the first of which is called comparing the safety and efficacy of different treatments for pathological scars. Scars, I think we all know them. We probably all have some scars. Scars are essentially fibrous tissue that replaces normal skin after wound healing. And when we think about wound healing, we can visualize this as sort of a spectrum. And on one end, we have regenerative healing, which is healing without a scar. In the middle, we have normal scarring. And on the other extreme, we have pathological scarring, which is my main topic. Each year in the developed world, up to 100 million people get surgical scars. And up to 60% of these scars can develop into pathological scars. So why are scars a problem? Besides, obviously, the cosmetic concern, they can cause functional symptoms such as itching or pain. They can also limit movement. How do we treat them? We have many treatment options available, actually, but to this day, we have no consensus on which of these is the best. And so it is our aim to assess which scar treatment leads to the best outcomes. Our clinical question is this, and for this end, we are going to investigate patients with pathological scars. We are going to compare multiple treatment options, and we are going to look at the improvement of these scars measured with different types of standardized scales. And our hypothesis is that the combination of therapies and treatment modalities leads to better results. And our implication would be, obviously, a more evidence-based approach to the treatment of scars. I have here three of my many key articles. These all have patients with keloids or hypertrophic scars, which are the two main types of pathological scars. We have multiple treatment options and also combinations of treatments. They all assess the before and after change in the scar metrics assessed by the so-called Vancouver scar scale, which is the most commonly used. These are all RCTs, as we are conducting a network meta-analysis. And we are currently in the title and abstract selection phase. For my second topic, we are also conducting a network meta-analysis, and it is a very similar topic, but here we want to focus more on the prevention of scars altogether, of pathological scars, and especially in the context of postoperative pathological scars, because as I've said, between 20 to 60% of surgical scars can develop into pathological scars. And I think it's especially important to mention the psychological component in this, because I've personally met people who were hesitant to undergo necessary surgery because they were afraid of how the scar might look afterwards. And in this topic, we also have no consensus on which therapy to use. Our clinical question is which intervention is best at preventing postoperative pathological scarring. We are going to look at patients who underwent surgery. We are going to compare, once again, many of the available therapies, and we are going to assess the severity of the surgical scar, also with standardized scar scales. And our hypothesis is that certain treatments are superior at preventing pathological scars, and probably the combination of them leads to better outcomes. And once again, our implication would be a more evidence-based approach to the prevention and treatment of scars. Here is our search key. In the first domain, we have the types of scars we want to look at. And for the second domain, it's just that we are looking for RCTs in order to conduct a network meta-analysis. We have not found any previous systematic reviews or any Prospero registration. And here is 3 of my key articles. These actually all have women undergoing breast surgeries. And as you can see, we have multiple interventions. And once again, we assess the outcome with the so-called Vancouver scar scale. And these, all of these studies are actually within subject trials, which means that these patients underwent operations on both breasts, but only one of them was treated with the scar prevention therapy. So we have the best possible comparator, which is the patients themselves, essentially. So in summary, we are conducting 2 network meta-analyses in the topic of pathological scarring, with the first one focusing on the treatment of existing scars, and the second one focusing more on the prevention of postoperative pathological scars. And I would like to close my presentation with a quote from Niccolò Machiavelli, which is, "Where the willingness is great, the difficulties cannot be great." Thank you all for your attention.
Thank you. Just one comment. However, this is a gynae-urological group. The most highlighted topic is the plastic surgical one, so we should expand our name is not just gynecology, urology, but plastic surgery as well. However, we are facing the problem with the scars tissue. We are doing surgical procedures. So, any questions?
Great presentation, great progress. So, from your preliminary results, what do you think, which is the best for treatment and for prevention?
I cannot say a definitive answer yet, but my vote would be for botulinum toxin and steroids in combination for the treatment of scars.
From prevention?
For prevention, I'm really not sure at the moment.
Okay, hi, great presentation. And I would like to ask, do you think there are differences between the different parts of the body where the scar is, how big the scar is, what kind of indication was for the surgery that was?
Yes, that is a great question, I think. Ideally, most of the studies are what are called split scar studies, where we have one scar and they treated one side of the scar and they used the other treatment on the other side of the scar, or no treatment according to the study. And so in that regard, I don't think it matters to the extent it would if you had different people compared, because we have the same scar and we have we are comparing the 2 sides of the same scar. So in that regard, I don't think it makes all that much difference, but we are going to consult someone more experienced on that.
Okay, thank you.
Congratulations. It will be a hard job to do a network analysis. Could you tell us which are the main methods in the prevention which will be analyzed? Which are the main?
Yes, that's a great question. We can categorize them really mainly into laser treatments or pharmacological treatments. Most often, I would think they used steroid injections into the into the wound during surgical closure, for example. So that's mostly steroids, laser therapies, or recently Botox is really getting some ground.
Are there any predictors for a higher risk? I mean, the patients who's got higher risk for developing such scars, except of the genetic factors. We always tell the patients that because of the genetic factors, but do you know, are you aware of some kind of other factors?
Race actually has something to do with it. So it is established that people from Africa, for example, are at a higher risk for developing keloids. So we ideally want to, if we can find any info on the race of the patients, we would like to include that, or the ethnicity, yes, or genetic background.